entrar. ¿De acuerdo?
Session, and I welcome you and I welcome all of you for this very, very important webinar. And the title of our webinar is Public Health Epidemiology of Diabetes and its Risk Factors. And this webinar is organized by Public Health and Epidemiology Interest Group of the ADA, along with the AMNET, along with the University of Antigua, University of Florida International University, the International Diabetes Federation, and APHA, that is the American Public Health Association. So we have large number of organizations who have joined us today for this webinar. And this webinar happens to be a special webinar organized on the occasion of the World Diabetes Day. You know that 14th November is celebrated all across the globe as World Diabetes Day, and we are here for this. And we have a very interesting lineup and very renowned and very eminent speakers with us. Just to give you a description about the webinar, we will provide and try to explore the epidemiology of diabetes and trying to present critical insights into the global patterns, risk factors, and impact of this growing public health challenge. And we have with us Dr. Peter Swartz, Dr. Sagar Dugani, we have Dr. Noel Baringo, and Dr. Pola. So first of all, I would like to introduce Dr. Peter Swartz. Dr. Peter Swartz is currently heading the IDF, and he's the current president of the International Diabetes Federation. And he is working tirelessly to improve the lives of people living with diabetes. Dr. Swartz is from Germany, and he is internationally recognized for his groundbreaking work in diabetes prevention, lifestyle intervention, and public health strategies to curb metabolic diseases. As IDF president, he is playing a pivotal role in shaping global diabetes policy and advocacy, solidifying his influence as a leading figure in the global response to diabetes and metabolic disorders. So he has joined us live, but he is in a poor network area. So he has recorded his session and sent it to us. And I will request Dr. Noel to play the session. Dr. Noel, we are not able to hear the audio.
No, your micro is deactivated.
I think you need to unmute yourself.
You can't hear it?
No, we were not able to hear it. Probably you need to unmute yourself when you play the video.
Unmute? Okay.
Unmute yourself and maybe click on share the sounds.
Let me see. All right, we can try that. Let's just have a lot of background noise here, but I'll see if it
was working in that way.
All right, then probably it's okay. Let me see. And
dear ladies and gentlemen, dear colleagues and friends, I'm Peter Schwartz. I'm Professor for Prevention and Care of Diabetes, and I'm President of the International Diabetes Federation. It's a great honor for me to speak here today on this webinar on behalf of World Diabetes Day, because this year's World Diabetes Day is unique. About myself, as I said, Peter Schwartz, I'm leading the International Diabetes Federation, an umbrella organization of 242 diabetes organizations in the world, the largest NGO, and an NGO which is in every country in the world. And this is a very powerful momentum that we are present in every country worldwide with our member organization. And this is the passion, this is the energy, this is the momentum to be used for improving quality of diabetes care worldwide. World Diabetes Day this year, it was actually yesterday, the 14th of November, and the theme this year is diabetes and well-being. 70% of the people living with diabetes experienced impacts on quality of life. 80% already experienced burnout due to diabetes, and 75% of them ask for support, and in most of the cases are not getting it. This has to change. We should not accept this, that well-being and quality of life of people living with diabetes is ignored. We as healthcare professionals often look at diagnosis, pharmacotherapy, management of the disease, and look at the outcome, and forget about the needs of people living with diabetes and forget about quality of life. This has to change, and the International Diabetes Federation will put the finger in this to make a change, to support a change, to enhance the capability and the skills of healthcare professionals and diabetes team to ask about well-being, to do in small, little, larger or big steps to do something to improve well-being and quality of life of people living with diabetes. I mentioned that the day yesterday is unique because of several aspects, and the second aspect was WHO, because WHO released yesterday information that there are 830 million people living with diabetes on Earth. This is much higher than we had expected from the International Diabetes Federation. And WHO highlights that over the last 30 years, the number of people living with diabetes have quadrupled. And what do they say? Also that less than 50% of the people living with diabetes take their medication or have access to medication, and that there's a significant increase in the development of complications related to diabetes. We had a very intensive discussion yesterday about this discrepancy of the number from the IDF and the WHO, and looked into the information in India, because I'm currently sitting here in Delhi in India, and the question regarding this data is somehow related how to diagnose diabetes, which number to include, and this can be discussed in the upcoming weeks. But the important messages, there is a tide of diabetes. There is a significant, continuously increase in number of people living with diabetes. And we have to build a global community of passionate people who are dedicated to do whatever we can do to improve the quality of diabetes care worldwide. And this is where IDF stands for. The current situation is a challenge if you are looking into diabetes. And there are pictures of people living with diabetes. Here, a young lady from India, she was diagnosed with type 1 diabetes as she was 11. And her mother gave her a can of petrol to burn herself because the family cannot afford insulin. Here, a picture of a father with a type 1 boy from Congo. And he told me that he has to, he earns his money every day. So he has to decide buying the insulin for the child or the food of the rest of the family. Other pictures, you can imagine where this is in the Near East, in Lebanon and in Gaza. There are many diabetes patients, many children with type 1 diabetes in Gaza, and to many of them, the contact is lost, but we are pretty sure that the colleagues in the region do a passionate work to help them, but the circumstances are a disaster. Other people living with diabetes in Africa who don't have access to insulin or to therapy, but also the optimistic side, again, Gaza, with a lot of passionate people to do whatever they can do to help in the region, to help in other disasters worldwide. And this is what the International Diabetes Federation is about. But on such a day, if we talk about diabetes, we also have to understand the shift in understanding the disease. Here's a picture. And you might say this is the increase in prevalence of diabetes in the future. It is not. It is the increase in air pollution in relation to diabetes. And if you stand 5 minutes behind a nice, let's say, a nice German diesel car, and you take a few deep breaths, medium-sized particles out of the diesel engine, you can find 2 weeks later in your insulin-producing beta cell, especially for type 2 diabetes. This could be a determinant in the future. So it could be that air pollution becomes a relevant health determinant, a public health determinant, or climate is becoming a determinant for diabetes prevalence. Because today we don't fully understand whether these particles in the beta cell have an effect, but in cell culture it does. It reduces insulin secretion by 30%. So climate may become a future health determinant, but we always say we have to understand pathophysiology. And the development of glucose sensors was a brilliant teaching momentum for us as healthcare professionals, because we got in touch with a disease we haven't known before, because we always looked at too many patients and we did not fully understood the healthy situation. And here you have an example of a young woman, high normal A1C. She's always snacking, and the purple line is glucose, measured 1,440 times a day. There is nothing. This is a person being very insulin sensitive. She needs maybe 1% of her insulin to regulate blood sugar, and there's no fluctuation. In comparison to this, her father, it's truly her father, and look at this, the father has a better A1C, a fully healthy A1C, but you see in the morning and the evening, good glucose curve, and then you see some fluctuations, also going above 7.8 millimole. And the difference to the daughter is the father is very insulin resistant. He needs about 80% of the insulin the pancreas can produce. And so if he is eating something, then some fluctuations are starting, because the beta cell cannot compensate the increase or compensate the glucose as fast as for the daughter. Because if he is at 80% insulin resistant, he only can increase to 100%, and this is not enough. So this is prediabetes. This is someone having a high risk of contracting diabetes in the next 3 to 5 years. And this would be the right moment to do prevention. Unfortunately, we don't find them because we cannot use a sensor for screening. But what does it tell us in the future? If we think about the fluctuation, if we have two people with A1C of 7, one has mild fluctuation, the other one has big fluctuation. The one with the big fluctuation has a high risk for a stroke and a heart attack. The one with a mild fluctuation may not even need an intensive treatment. So this should be the new treatment paradigm in the future, reducing fluctuation of glucose. We also have to understand patients. We have to understand ourselves. And here you see 380,000 patients here on the slide. And what happens if you drink one soft drink per day for 1 year? So 365 times. What it does with your diabetes risk. If you drink water, nothing happens. Orange juice, 40%. Coke, 40%. Diet Coke, Coke Light, Coke Zero, 60%. How can this be? How can the Coke without sugar make more diabetes than the Coke with sugar? The answer are artificial sweetener, because they are changing the microbiome. It's another aspect of diabetes, the bacteria in our gut. And this change of microbiome, there are 13 to 14 different germs invading the gut, and they produce fatty acids onto glucose. And this microbiome, it's in our gut. So we incorporate these substances, this metabolite, into our bloodstream, like the fat from tiramisu. And where is getting this stored? In the liver. But there's also a lot of hope. The hope is digitalization. And I truly believe that smart health and digitalization and digital therapeutics can be disruptive in the way we do diabetes care. Here you see how our drugs lower A1C, how lifestyle is lowering A1C, and how digital tools are lowering A1C, especially young digital tools. What are young digital tools? Smartphone-based apps. Now you might say, how can a smartphone-based app lower A1C? It's impossible. It's a smartphone. The answer is very simple. We are in the pocket of our patient. We never have been so close to our patient than being in the pocket. Every one of us is taking 1,800 decisions a day. 450 are related to our lifestyle. Now imagine that in the right moment, with the right motivational strategy, the right content, impulses are set to influence only 10 out of the 450 decisions. But this over the period of 1 year. So intuitive intervention out of the pocket of the patient, we may translate this into 10 kilograms of weight reduction. And why not modern diabetology should look like this? I think there's nothing to fear. We should foster this. We should initiate this. We should use this to reach a patient clientele which we otherwise would not reach with other matters. And some examples here, it's a licensed and reimbursed app which has done RCT trials to show the effect in Germany, doing diabetes education, mainly nutrition related. Another one using AI. You make a photo of your food and it's getting qualified and quantified, and they are very good in this, even if you use culturally diverse food items. And this information is used not to blame the patient for what he is eating, but to use the information to help him to improve the next meal. We studied this for 6 months, in comparing the first week of meals and the last week of meals. There are minus 560 kilocalories, so intuitive change of nutrition behavior. There are other applications using the sensor and using the curve of the shape of the sensor curve to target nutritional intervention. And here an example from Sweden, using the sensor and comparing all data of the patient with a swarm of 1,000 patients worldwide using the same device. And using deep machine learning and artificial intelligence to project and analyze the curve of the sensor. And then here using the 6 areas of diabetes care, making precise recommendation regarding therapy. For example, saying today at 6:35, you should inject 22 units of long-acting insulin. So here an example how the analysis is done. We might say, oh no, we don't want this. We fear this because we are the healthcare professionals or we are the diabetes teams. But think about Rwanda, 380,000 people living with diabetes and only 1 endocrinologist. So, and the digital infrastructure, which is very, also is better than, for example, in Europe. And this is a big opportunity, using digital tools, digital therapeutics to diagnose, to do prevention, to do diabetes care, supporting diabetes care in regions where we don't have or where there's low access to a healthcare system. So again, modern diabetology could look like this. I'm the president of the International Diabetes Federation, and serving IDF for me means taking all this information I just have presented and translating it into strategies to increase quality of diabetes care worldwide. And what is driving me is we have to address the need of our patient. There's nothing more important than addressing the intuitive need of people living with diabetes. And for me, this means everyone should have the same availability and accessibility of diabetes care. The care may vary, the needs vary, but everyone should have the same quality of accessibility and availability of diabetes care. And as president of the International Diabetes Federation, I have 3 goals. One is to be in the diary or in the brain of every healthcare politician or health politician. I want to be in the pocket of every diabetes patient, and I want to be in the heart of every healthcare profession. How to reach the first one, the brain or the diary of every health politician? We will start a global diabetes index. Once a year, we will measure with 100,000 patients and 100,000 physicians their perception about the quality of diabetes care, very much related also to accessibility and availability. We will analyze the data. It's 121 questions, translate this into an index, and we will release the information 4 weeks ahead of World Diabetes for free to anyone who wants to use it. But immediately this makes the quality of diabetes care comparable between a state in India and Wisconsin, or Finland and Suriname. What will happen? So the stakeholder in the country might go to the Minister of Health and say, our country scores at 65, but our neighbor at 75. So let's do something to improve. Maybe he's ignoring. Next year we do it again. And then maybe the country stays at 65 and the neighbor has improved by 3%. And then people come and say, why have you not done anything already last year? So we want to build a momentum for the politicians to change. I want to be in the pocket of every diabetes patient. And you can imagine who is in the pocket. It's Google, it's Meta, it's Alphabet. It's working with these organizations to develop and strategy of free accessible diabetes education for anyone in the world who has a smartphone. I know there are people not having a smartphone. I know that this is a limitation, but using a smartphone-based strategy, we will gain also a lot of access and a lot of distribution to a community who has no access yet to diabetes education. And this is where we want to focus on. And for those people who do not have a smartphone, we will add continuously aspects also to give access to them. So using a digital education program addressing the need of patients or people living with diabetes, this will be one of the policy and strategic goals of the International Diabetes Federation. And thirdly, being in the heart of every healthcare professional, we will develop a fellowship program of the International Diabetes Federation, and we actually start it today in India at the RSSDI meeting, and today at the webinar we just have. And this will mean building a global community of healthcare professionals who are passionate about improving the quality of diabetes care. So we think, or we start today the IDF fellowship program. There will be also a senior fellowship. This is for people who have about 15 years experience in diabetes care. The fellowship program is for anyone who is interested in diabetes care. And they will have access to everything from the IDF School of Diabetes for free. So the goal is that healthcare professionals who are interested in diabetes in Congo, for example, who do not have the money to participate in the large congresses or to travel, we will deliver targeted, evidence-based, high-quality diabetes education on the computer at their desk. So if you are a healthcare professional listening to this, the IDF fellowship program starts today. And if you are interested, I would love to invite you to, or I'm inviting you to become fellow of the International Diabetes Federation, the global community of actors in diabetes care. The goal is to leverage know-how and skills to translate it into better diabetes care, being the catalyst for high quality of diabetes care. There will be the senior fellowship program and the fellowship program, and the fellowship program opens in this moment today. So if you have your smartphone, use a chance to scan this QR code. There will, in the next slide, another one as well. This QR code will direct you to the fellowship program. And this is my QR code. This is my WhatsApp channel, and I'm inviting you. This is something I really do with my hands, and I want to give want to witness or will show you the activities of the International Diabetes Federation on day-by-day basis, what I'm doing, what IDF is doing, but it's me doing it. There will be nothing commercial on this channel, and I'm inviting you, if you are healthcare professionals, if you are a patient, if you are a member of a diabetes team, or you are a politician, join this community and use this to get engaged with the president of the International Diabetes Federation, because you can comment, you can give feedback, you can say, Peter, oh no, I don't like this. Maybe you should change this, or I have an idea I would like to share with the community. You are very, very welcome and warmly invited to participate. Finally, also other channels on the social media where I'm inviting you to participate. Use the WhatsApp channel, then you are connected to all the other ones as well. There are a lot of faces of people living with diabetes. Let's act together. Let's not only talk about this, let's walk together on behalf of the quality of care for people living with diabetes. And with this activity, we should put a smile on the faces of these people living with diabetes. Again, the QR code, and let's work together. As a global community, let's work together and being passionate about improving the quality of diabetes care, but finally help our patients or those with pre-diabetes to walk away from diabetes. Thank you very much for your attention.
That was a wonderful talk by Dr. Peter. And unfortunately, he is not able to join live because of some network issues. We have with us Dr. Sagar Dugani, Dr. Noel Baringo, we have Ola, we have Luisa. So I will request a quick one comment from each one of you about Peter's statement and this opening talk of this webinar. So Sagar first, then Noel, then Ola.
Thank you, Dr. Amit. I think that was a fantastic opening, very inspiring. It's also somewhat sobering that as of yesterday, we're still talking about millions of people across the world that have diabetes. But I think what the IDF is doing, particularly with the fellowship program to create a global community, help everyone get up to speed and advocate for patients, I think is fantastic. So I completely agree. It would be great for more people to join the community and join the IDF fellowship program. So thank you.
Good.
Noel?
I agree with you. I like that there's a new fresh wind like through IDF, and there's a lot of communication going on and transparency, which is important. I joined the channel already a couple of months ago, and it's really it's great to see what our IDF president is doing on a daily basis, like for IDF and patients with diabetes. Really, I think it's a true leader and a true leadership, like how he manages through diabetes. We have been working actually with the president, with Amit and with Paula on IDF interest groups, and we hope that they're going to be launched soon as well, and to start with 3 interest groups. And I hope this is our way how we contribute to IDF and together grow in diabetes prevention and support our patients.
Hello, everyone. Thank you very much, Dr. Peter. I am absolutely agree with that. It's absolutely important to work together. This will be also one of my invitation in my short talk, but the IDF umbrella organization have the power of really join so many interests, people, communities, academics, but everyone that really want to contribute to the stop the diabetes around the world and the suffering. People is suffering with diabetes, so it is very important to work together. And thank you, Dr. Peter, for this kind invitation to join, to think together, to do more together, to really expand our collaboration, our network, and really think as a one whole being in order to have more, maybe, hope in the world. Thank you very much.
Thank you all, and thank you all the viewers who have joined us, all the attendees. Now we move on to our next part of the webinar, and for this we have Dr. Sagar Dugani with us, and we are again equally grateful to Dr. Sagar because he is also traveling within a couple of hours, and I guess he is also at the airport. So this is how the dedication of all the faculty, I can see they're still very much involved, and they want to convey the right message at the right time on the World Diabetes Day. Let me just introduce Dr. Sagar. Dr. Sagar is a very good friend of all of us. He is currently at the Mayo Clinic, and he specializes in diabetes, cardiovascular risk management, and metabolic health. He is dedicated to enhancing diabetes care and advancing research to prevent complications associated with metabolic and CV conditions. At present, Dr. Sagar is also the stream lead for the public health and the epidemiology stream for the scientific sessions of the American Diabetes. So Dr. Sagar, a very warm welcome from all of us for this webinar, and we will request you to proceed with your presentation.
Dr. Amit, thank you very much, and thanks to you and everyone else for inviting me. And you're right, I am at an airport, so if it's a little noisy in the background, I'm sorry. I try to use headphones, so it minimizes that. But thank you very much for this invitation. And I think Dr. Peter Schwartz has laid the right foundation to try and understand what the global burden of diabetes is. And it's also a wake-up call for all of us to understand how this is going to change, mostly increase over the next few years, and how we all need to work together. So with that, I want to share some information on some of the risk factors, because after you hear Dr. Schwartz's talk, one of the questions you ask is, what are the risk factors and how can I think about the risk factors? What can we do about the risk factors? So that's what I would like to share today, is information on the epidemiology of risk factors for diabetes. As Dr. Amit said, I'm at the Mayo Clinic, and there I serve as a research chair in hospital internal medicine. So we take care of patients who are admitted to the hospital for medical conditions. I'm also the vice chair of research in the Department of Medicine, and also the associate director of community engagement for all the Mayo Clinic sites. So my disclosures, I received funding from the NIH, also from the Robert and Elizabeth Strickland Career Development Award, and then some work from Dahlia Philanthropies to look at diabetes and rural populations. Most of my work right now is based on research, and this is research looking at diabetes and its complications, so cardiovascular disease, heart attacks, and stroke. And then the rest of my time is spent on the hospital service, where I provide care to adult patients who are admitted with medical conditions. A lot of my research is based on observational studies and clinical trials. And we also look at health disparities. And when we look at this, there are many ways to study or understand health disparities. And I'm looking at it from the lens of how race affects disparities, region, and we do a lot of work in the United States, and there are many differences for people who live, say, in the southern United States, or the Northeast, or the Midwest, or the West. And then we also look at rural and urban differences. We know there are many disparities for people living in rural areas, so we're trying to understand what those disparities are and think of ways for us to intervene. And I also serve in public health roles in the state of Minnesota. I'm on their Rural Health Advisory Council as well as their Human Services Advisory Committee. So today I would like to share some thoughts and the literature on the epidemiology of risk factors for type 2 diabetes. And then once we talk about the risk factors, the question that will immediately arise is, how can we improve them? So I'll share some information on frameworks to manage risk factors. There are many risk factors for diabetes, and today I thought of focusing on a few of them. It doesn't mean the others are not important. I just wanted to talk about a few risk factors and then maybe highlight some of the others toward the end. So the first one is obesity. We all know that obesity is a major risk factor for diabetes, and the global burden of disease has done an outstanding job of, it's a very difficult task of putting together the literature and studies from all over the world to try and understand what the global burden of disease is. In doing so, they recently had a report where they talked about the burden or trends in overweight and obesity. They defined overweight using this body mass index cutoff of 25 to 29, and obesity was defined as a BMI greater than 30. So I think most people who are listening to this will immediately have a reaction and say, well, we haven't adjusted for race. And you're absolutely right. There are different ways in which these cut points can be changed. For example, for Asian populations, some suggest that the overweight cutoff should not be 25, but it should be 22 or 23. And obesity should not be 30, but it should be 25. So I think there are many ways to think about this and re-stratify people. However, for the purpose of this, because this is the way the GBD study did it, we'll go with these definitions for overweight and obesity. They also used an interesting index called the SDI, or the sociodemographic index. And this is a combination of looking at income per capita, the education, and total fertility rate. And then they divided everything into 5 categories, all the way from low sociodemographic index to high sociodemographic index. They looked at data from 1980 to 2015. And what they observed in 2015, 108 million people had obesity. And they saw that the proportion was higher in women compared to men, and the highest prevalence was found in women aged 60 to 64 years. So this is a fairly busy graph. So let me share how this graph was done. So if you see at the top, there are actually 2 lines. One is for men and the other is for women. And you can see different lines. And then you have everything else for the low middle SDI, middle SDI, high middle SDI, and high SDI. And you can see the different trends for men. So for men in general, it's the dark line. So you have one line for men here and another one, all the dark lines. And then you have the dotted lines for women. And you can see in general, looking at the adults, it's higher for all the different colors. So if you just compare the 2 yellow colors, it's higher for the dotted line compared to the bold line. So that means it's higher for women compared to men. And that's the same for all of them. So no matter which sociodemographic index we look at, we see that the prevalence is much higher in women compared to men. We're not going to focus too much on children because I think children are a special topic and we need to think about the risk factors for diabetes separately. But what we can see is obesity in children has also been increasing from 1980 all the way through 2015. And again, we see the dark line is for men and the dotted line is for women. And we see that it's higher for the most part for younger male children compared to females. When we look here in adults, again, we see the trends from 1980 all the way to 2015, where in general, the trends are overall increasing. And it doesn't matter what sociodemographic index we're looking at. What was very surprising is that in 2015, high BMI accounted for almost 4 million deaths. And so then that raises a question, there is such a high burden of overweight and obesity. How do we think about the obesity burden and what can we do about it? And this is a framework that was published by the WHO. And they talk about different ways of addressing obesity. So they let's start on the left side with primary prevention, going all the way to secondary prevention, tertiary prevention, and then there are two aspects to that. But let's start again with primary prevention. So they feel that even being able to prevent a person from developing obesity is probably the best way to go, because once a person develops obesity, it becomes very difficult to then try to reduce obesity. So they talk about thinking about the risk factors for obesity, promoting healthy behaviors. And as Dr. Schwartz said, there are probably many different ways. Many people in the world have a smartphone. So it's important to think about other ways in which we can use smartphone technology or AI technology to help people develop healthier behaviors. And then we take a secondary prevention. So these are people who are at risk, who already have some risk factors. So looking at periodic health examinations and thinking about early counseling and interventions. And then we move to the next one where people have developed obesity. So this is established obesity. And here we have to ask, how can we treat obesity? What are the potential interventions? There's a lot of talk in the media, the literature right now about using drugs to reduce obesity, and many of them are very popular. But there are also a number of non-pharmacotherapy options that can help to reduce obesity. And then the final aspect here is controlled obesity. So where we want, if a person is able to manage their obesity, then we want to make sure they continue to get that level of care, they're able to maintain it, and also help with rehabilitation and self-management. So at each of these steps, you can see in going from primary to secondary and secondary to the others, it's always about trying to prevent people from getting to the next stage. And that's the best way to do it is to try and do it in a more people-centered care model. So that's what the WHO has also discussed here, is having a person-centered model where we may have a number of options, but we want to think about the person, we want to think about the family context, the community context, and then also think about the larger factors, which are going to vary from country to country. So what are the service delivery options? What are the health sector options? How about the other sectors? Is there clear sanitation? We heard from Dr. Schwartz about environment. What is the role of environment in increasing risk for diabetes, and how can we make changes there? And all of this is going to be an integrated health service model where we can try to prevent disease, prevent obesity development, and then everything else along the continuum. The next one is physical inactivity. And here again, a study where they looked at data from almost 22 years of data, and they defined inactivity as not doing at least 150 minutes of moderate to intense activity, or not doing 75 minutes of very vigorous, intensive activity over a 1-week period. And there are a lot of data here, but I just want to highlight one thing. So if we look at prevalence in 2000, prevalence in 2010, and then again, prevalence in 2022, overall, so globally, we can see it's gone up. It was 23% in 2000, and now it's 31%. And then we can look at all the different regions of the world, and in almost all of them, it's gone up. So 29.7 to 38.5, 15.4 to 22.7, and so forth. Now, in some areas, for example, in sub-Saharan Africa, you may see that the prevalence of obesity is going down, but there may be a different condition or concern, for example, malnutrition and not having access to nutrition, and that's something that also needs to be explored. In this graph, they wanted to try and understand if there are differences between men and women in all the different regions. So they had data on about 100 or so countries, and they mapped out the areas where the burden is different in men versus women. So on the x-axis, we have insufficient activity in men, and on this side, we have insufficient activity in women. And you can see that there are a number of countries where they are outliers, and there's a very big difference between how men and women are getting sufficient physical activity. So the WHO has a global action plan on physical activity, and they've identified 4 policy areas. And those are shown in the big circles here. It's about creating active societies, active systems, active people, and active environments. And there are 20 policy actions in total that are related to these 4 strategic policy areas. And they feel that it's important to work on this, not just because of, thinking about obesity or physical inactivity, but 500 million cases of non-communicable diseases can be prevented. And most of these will be related to hypertension and depression. So there will be impact both on physical health as well as mental health. And the final one is hypertension. And here they gathered data from 1990 to 2019, and they defined hypertension using these cutoffs. And we can see that when we look at the globe from 1990 to 2019, the burden of undiagnosed hypertension, that's shown in red, has increased. Diagnosed but untreated has also increased, that's the orange area. And then the light green is treated but not controlled, and then controlled hypertension. So everything is increasing, even the amount of controlled hypertension is increasing, but we still have a very high burden of people who are undiagnosed, and they may end up with more catastrophic complications like strokes and other complications. So it's important to think about how we can diagnose hypertension first and then help people control it. And I'm not going to go through all of these, but you can look at any region of the world, whether it's high-income Western regions to East and Southeast Asia, all the way to Sub-Saharan Africa. And in all areas, over time, the burden is increasing. There are a few areas, for example, maybe in Central and Eastern Europe, where the burden of undiagnosed hypertension is going down, and maybe somewhat even in high-income in the Western world. But for the most part, you do see that the burden of undiagnosed hypertension and controlled hypertension are all increasing. What was very striking is that from 1990 to 2019, there was a big increase in the burden of women with hypertension. It almost doubled, and for men also it almost doubled. And I'm not going to go through all of this, but I just wanted to show that no country is immune from the burden of hypertension. And the article has a very nice infographic, which is easier to see and read, but there are a lot of variations across the globe. So in some countries like Canada and Peru, where it's the lowest prevalence, and then in other countries where the treatment is the highest, for example, in South Korea, Canada, and Iceland. And then there are places where the treatment is very low, only 25%, less than 25% of the women in some countries, and less than 20% of the men receive appropriate treatment for hypertension. So as we think about all of these, I just wanted to share that there are frameworks that are going to be global, for example, the WHO, but then you may also have some frameworks that are going to be country specific that take into account local factors, regional factors, or national factors. And in the United States, they had a framework to think about diabetes, and they came up with the recommendations at the population level, high-risk individuals, and people with diabetes. And they ultimately came up with 39 recommendations that should be implemented. I won't go through all of this because it's fairly complex, but it just shows that in order for us to make a serious dent in diabetes in the way that Dr. Schwartz was discussing, we need several sectors to come together, whether it's the government and public policy sector, it's the behavioral setting, individual factors, healthcare, and then all the way along the lines of population health and health equity. So it's not going to be easy to change the trajectory of diabetes and its risk factors, and you need a much larger involvement and partnership for this to happen. So with that, I would like to conclude and just share a summary that the burden of risk factors is increasing over time. There are also sex differences and country differences. Global frameworks are very useful, but then they may need to be customized or tailored to a particular country, taking into account its local, regional, and national contexts. So with that, Dr. Amit, I'll stop and I'll hand it over to you. Thank you.
Thank you, Dr. Sagar. Again, it is very important that Dr. Peter highlighted the importance of prevention, and you exactly talked that what is contributing to the rise in epidemic of diabetes and what are the risk factors and what is their epidemiology. So I would just like to, I know you have to have a flight to catch, so maybe I can have a couple of questions right now with you. What is your take on this latest release of WHO data? I think it has become talk of town all across the globe. So what is your take on that?
No, I completely agree with you. I think the WHO report is timely. I think it's a wake-up call for everyone to recognize how big the burden is. And even though we talk about health systems, we talk about cardiovascular disease, we talk about stroke, we talk about mortality, but I think diabetes is one way that is sort of a gateway condition that leads to many of these risk factors. So I think it was a wake-up call for everyone. It's much needed. And I think there are some global strategies that can be put in place where everybody works together, because if there's environmental pollution in one country, that's going to affect the neighboring country too. It's not going to affect just one country. So I think there are strategies where we can think about it globally, but then also how we can be more effective at a local and regional level.
I think that is very right, because it is really indeed a wake-up call, because and we need to step up our efforts. So I will laud the efforts of ADA, APHA, IDF, that, and this is the time we need to come together, because uh, we are doing our bit individually and now all the organizations, they are also coming together. And this is the time that we now do a lot for the diabetes. So we have questions here that from Dr. Pradeep Gupta, and he is asking to all the panelists. And the question is that, uh, do you think there is importance of preschool check in early diagnosis of hypertension and diabetes? Sagar.
Yeah, I think that's a great question. And I think we have a very limited understanding of when hypertension actually starts. We don't know, are there risk factors in children who are 10, 12, 14? We know that diabetes is increasing even in younger children. Earlier, we talked about, adult onset diabetes. Now we just talk about type 1 and type 2 because you have a lot of people at the age of 18, 16, and 14 who are developing diabetes. So I think that's a great point. We need to understand the risk factors better, particularly hypertension. We recognize obesity because it's more visible, but hypertension is without symptoms and people can have hypertension for a very long time. So I think that's a very important point to think about how schools, and because children spend most of their time at school anyway. So is there an opportunity to think about screening for hypertension in schools?
Thank you, Dr. Sagar, for the question. Thank you, Dr. Pradeep, for asking that important question, and that really adds value to the webinar. And thank you for joining us. So, Dr. Sagar, thank you once again from the entire team of our public health interest group of the ADA for joining this webinar. Now,
Thank you,
Noel,
Dr.
a brief comment from you and Paula, then we can move to the Paula's talk.
No, very brief. Congratulations. Really well explained, like the current standing, and I think the WHO reports it's came out in timely manner, and everything, the information we have, it's also time for the action component. I mean, I know today it's about the epidemiology, but everything this helps is giving a solid foundation why to make changes and to monitor the changes over time. So I think it's congratulations for a great presentation.
Thank you, Janvir, for asking this again very, very important question and joining us for this webinar. And Janvir is asking, is it time to apply primordial prevention? So I think any one of you can answer. Yeah.
No,
Please,
I think that's a great point, and thank you for asking that. We need to think about primordial prevention because that will actually have an effect on a number of conditions, even just not thinking about diabetes. If we think about healthy nutrition, if we think about obesity, body weight, and hypertension, that will have an impact on diabetes. It will have an impact on cardiovascular disease. It will have an impact on a number of things. So I absolutely think that's the right way to go. And if you can start at an early age for children and focus on primordial prevention, we'll probably get the most benefit from it.
Thank you, Dr. Sagar.
Last question. I absolutely agree, Dr. Tahar. I think that we have a lot of challenge in detection, early detection, and really go in the place where the people is. For example, schools, kindergarten, every place that we really need to start with people is absolutely important. Thank you very much for this motivation to do more for people.
So now it's time to learn something more about the epidemiology of diabetes in children, and we have with us Dr. Pola. So welcome, Dr. Pola, and let me just introduce Dr. Pola. Dr. Pola is currently she is a leading expert in the epidemiology of type 1 diabetes. She is serving as a professor in the epidemiology group at the National School of Public Health, University of Antigua. And in addition to her academic role, she is the president of AMNET, and AMNET stands for the Americas Network for Chronic Disease Surveillance. And we are very, very thankful for the AMNET for making all the arrangements for the webinar and providing the support and platform to organize this webinar. So welcome, Dr. Ola, and I will request you to proceed with your talk on prevention of type 1 diabetes, focus on high-risk preventions, populations, and so welcome, please. Kindly unmute yourself. Yeah.
Yes, let me share again my screen. Okay. Hope that. Could you see my screen now? A full screen? Okay.
Yes.
Yeah.
Perfect.
We can. Yeah.
Okay, thank you very much for this kind invitation. I love to share some small ideas, really with a lot of humble, some situation about the global epidemiology of type 1 diabetes. This is one small disclosure. I really don't have any conflict of interest, but I have a deep respect for all people that really live with diabetes. And this is one invitation again to work together to make the difference in people that really live with diabetes all the time and has to address all these issues in their lives. So I will move, let me 1 second, I try to just move this small thing here. Yeah, it's okay. So I will move back. A little context, I will just talk a little bit about the global overview of type 1 diabetes, some variation about the incidence across the region that is very important, some differences between age and gender, and the problem of recent incidence, a small reflection about the environmental and socioeconomic influences, and some global burden of economic situation of type 1 diabetes and the future. And the most important, how can we also collaborate together? This is the first slide. Dr. Sahar mentioned it before. This was a publication just appeared in our world 2 days ago, and this was very, very surprising for all of us because they say that now we are between type 1 and type 2 diabetes more than 800 million of people. But also in this amount of people, half of these people, more than 400 people, live with untreated diabetes. This is absolutely painful, but it's absolutely dangerous for people with diabetes type 1 that needs absolutely access to insulin to survive. So this is very important, but also if you can see the dots, the big dots in the global picture, you could see so many important places that now has in the last decades really appear with a huge incidence, and so many people now are suffering with type 1 diabetes. More or less 10% of all this population with diabetes are people with type 1 diabetes, and also in this amount of people, at least 1 million of people are less than 20 years old. So if we can imagine this picture, we are talking about childhoods really surrounded by stress situation that is very complicated, because we need to be sure that our glycemic, our glucose level, our life is surrounded by control and really avoid complications. So if we can imagine this picture for all these people, we really need to do something about it. This is a nice picture that happened, that appeared so many years ago, but is still very convenient, because what happened with the new century? Early in the 20th century, we really understand more or less that genetics and environmental factors were in an equilibrium, were more or less 50-50. But now we are more or less agree, and Dr. Saher really mentioned some a stressful situation like obesity, and maybe some disruptors, also air pollution, also so many environmental factors that we really don't know very well right now, but are really affecting the incidence around the world. If we will see 3 or 4 pictures after this. This was the original picture of Diamond, the wonderful project that was the first project in the whole world that tried to understand with real data what happened with type 1 diabetes. Professor Jaco Tumileto conducted as a leader this very wonderful project, and you can see the picture, and I would like to notice the white countries. So these white countries happening in 2006, but then in 2015, more or less the same, were also countries with lack of data, lack of information, the real information that we really need to do. This was one of my work during my PhD, but these pictures was updated in 2021, in 2019, and happened exactly more or less the same. So the invitation is what happened between all these years to really as a country, as a global citizens, as a whole world, try to really understand this phenomenon. This in this screen, you could see both picture, one for childs between 0 and 14 years, but also with people after 20 to 40 years. You could see that the problem is stronger in people after 14 years. So the next point that I would love to address is the variation by region. Really, our world is affected dramatically for big difference. We will see again with these maps, but the world could have more or less 350 folds of the difference between the countries with a very low rates of incidence and the countries with the very high rates of incidence. There are huge dramatically variations, but also there are variations across our world between countries with very low and countries with very high incidences. But maybe this is not something isolated. Maybe this situation has a lot of different explanations. One is genetically, of course, but also again, environmental factors could be affected, all this information that we have now. This is the prevalence and the incidence maps about the people with type 1 diabetes. You will see, for example, the huge amount of people in terms of prevalence that are now living with type 1 diabetes. The type 1 diabetes will be the most prevalent in disease for child that start with this disease across the life in the near future. So now it's very important, but time by time, this number of people will be increased and increased and increased. But also the incidence is increasing in most part around the world. What happened about the age and gender differences? What we will note, we note that the incidents appear mostly in people across the early ages, but also we find an excess of risk in men, that this excess is still persists across the whole world, so, and across the all regions. So it is important to try to find what happened with this excess, and what kind of strategies we will have. This is a very important excess, but also the presentation of the type 1 diabetes. It's mostly very well known that it's appear in young people. It's appear more or less between 5 and 14, but also there are some studies that show that it's important to really look what happened with type 1 diabetes in children under 4 and 5 years. But also what happened with people that has a late onset of type 1 diabetes after the 40s, 30s, 80s. So there also data. This was an example, a small review that we conducted, but now this was conducted in 2015, but now still there are a very huge and significant gap in this information across all age groups and regions. We really need to expand more epidemiological studies everywhere, but also we need to understand what happened with the incidence in type 1 diabetes across the all ages. We recall this picture that we saw before, but now in a big picture, we really would love to have all these gray spaces, all these gray filled with colors, to really understand what happened with type 1 diabetes also in adults. The reason in incidence is also one of our biggest concerns. In general, the world is experiencing an increase in the incidence of type 1 diabetes. But it's very surprising that this increase is very faster. It's more deep in countries where we have a lower incidence historically. We, in one of our small research, we saw the delta, the chains, these big chains. For example, in China, there's a very, very low incidence, but proportionally between the ratio between the first incidents so many years later and currently, this big change is very significant. Also, it is important to see what happened with people, as I mentioned before, in really childhood, very early childhood, between 0 and 4 years old. We saw also increasing. This will be certain slides that shows this phenomenon. In most countries around the world, the incidence is increasing. You will see this is another study that from Patterson that also tried to check so many countries across the Europe, and the phenomenon is exactly the same. And this is recently a paper published in Nature also that Bosch showed how across the different periods between 19s and 2020s, the incidence is increasing really significantly between, for example, the 7.7 here in 90s to 11 in the 80s, in the 20s, in the 2020s. So this is very significant and important. About the environmental and socioeconomic influences, we could see in the literature also some very important environmental and risk factors like viral infection, socioeconomic status, maybe urbanization related with air pollution that Dr. Peter mentioned before. So there are something new that maybe is affecting our genetics and our epigenetics, our microbiome. So there are something that there is still really pressure our situation across the world, the whole world, to increase the type 1 diabetes. Also, we could see the higher GPT per capita countries has the very highly potential people or amount of people with type 1 diabetes. Maybe this is a very coincident, but really it's important to understand what happened. And this is more or less the same information in another way. We could see, for example, countries like Europe has the highest incidence and prevalence, but for example, in terms of incidence and prevalence, also these countries coincidentally has the higher income, but the most surprising thing is this. These countries are the highest number, they has the highest number of deaths, the low middle income countries. So if we compare these two graphs before, there are most people with incidence and prevalence of type 1 diabetes in high income countries, but really where our childs, our people with type 1 diabetes is death, it's important to think about social determinants, inequities. So how can we will do to really offer the care, the treatment, the opportunities for all these people that live in low middle income countries to have the same opportunities and rights that has people in high income countries. There no should be difference about that. In terms of global economic and healthcare burden of type 1 diabetes, it's also very important to see the big differences, the big map. The big importance is really necessary to understand the war in terms of globally. This is the prevalence is really increasing, was increasing between 90s and 2009. This is again the paper version in published in Nature in 2014, this year, 2024. But also the incidence was increasing. The good news was a little contracted in the last year. And also the good news was possible to reduce across the whole world in terms of globally the mortality, but also was interesting to how can we really could reduce also the dailies, that is the number of days that people as off because of discapacity. But also we have some hopes. This is Finland. In Finland, we can see a little bit after being the country with the highest incidence in the whole world, with the incidence that address the amount of 60 and 70 people for 1,000 of people, we can really see a slow, very slow, but a tiny slowdown in this tendency. So this, to me, is hope. We can have the hope that it's possible to reduce mortality, to reduce burden of disease, to understand better the incidence and what happened with type 1 diabetes across the world in child, very, very young child, but also in the whole childhood, but also in the adults. It's all the time possible. So I would love to finish my presentation to one kind of invitation. You heard to me mention the diamond study, and we really would love to really rest with this idea of the moving forward and to consolidate again the strategies, global strategies to have more real data in type 2, in type 1 diabetes. So I invited you to read this small piece of paper published in The Lancet that really has an invitation to join as a group, as a whole world, to work together for this really dream. Happens before in Dar es Salaam, core expert group of people that really put this sentence and this invitation. Then we had a meeting in Geneva in 2023, and then we relaunched the Diamond 2 Action collaboration as this big need for the whole world. This is the nice, wonderful group of people that has the honor to be in these first conferences. I really want to mention and to say thank you, Dr. Jacopo Mileto, because he still is dreaming about this project, and he is still really putting people together to do all this effort to have this option, to have this dream, to have this opportunity to work. There are so wonderful people here, so wonderful researchers that you can see all of them here. And also, we would love to invite all of you that join this wonderful team, this wonderful group, because all together we have so much things to do. This is the final, but is a very, some thoughts. As a conclusion, the global incidence is really rising. It's important to understand more what happened with these differences, with what happened with our genetical but environmental factors all together. It's absolutely important to work together in these future researchers to understand what happened and to put in the agenda of the whole world the people with type 1 diabetes, and really all together we can make the differences. As a community, everyone has something to do. So thank you very much, and I am happy to have some conversation with you about the questions or thoughts. Thank you.
Thank you, Dr. Pola. And so there is a question, and I think attendees, all the participants, they are liking the presentations. And so the question is, can we get the materials? I think Dr. Pola to answer that. So Mr. Das has asked that can we get the materials? So certainly we will be providing you the recordings, and we will be putting it on some platform.
Okay.
And yes, Sagar is still there. Thank you, Sagar, for staying with us.
Perfect.
And, Pola, can we proceed with the Noel's talk first, and then we go to the discussion part at the end of the session?
Of course.
Is that okay? Yes. So let me introduce Dr. Noel to everyone. Dear participants, Dr. Noel is a very dear friend. He is currently at Florida International University. He is heading the research committee there, and he happens to be a professor of public health. And he is the immediate past chair of ADA's Public Health and Epidemiology Interest Group. And he is a very renowned researcher and has many publications to his credit. So, Noel, over to you for your presentation.
Thank you. Thank you very much for the invitation organizing this webinar in collaboration with the American Diabetes Association, OMNET, IDF, and the American Public Health Association EPI-section. I think we have heard really great presentations, and to round it up, as we talked about the epidemiology of type 1 diabetes, I'd like to talk about the epidemiology of type 2 diabetes in children and adolescents, which is, I think, a topic that is a daily growing of interest, and something we definitely need to survey, to monitor, and finding solutions to the growing epidemic. So I'm first going to talk a little bit on different studies we have, and you're going to see there are not that many studies as we actually expected in regard to the prevalence or incidence of type 2 diabetes in children and adolescents, then something about the complications, why type 2 diabetes in children is different than in adults, and what we should do for the next steps. So this is something we know that we can categorize people probably into positive and negative risk profile. We know that the factors that affect insulin secretion action has to do with modifiable lifestyle factors like body weight, visibility, smoking, as we've heard, also heavy alcohol consumptions. But there are also some factors we don't have a direct influence, that are really non-modifiable, at least not at the moment, such as like the genetic predispositions, gene environment interactions, gestational diabetes, and probably epigenetics. But all the cluster of negative risk factor profile probably leads into the beta cell dysfunctions and insulin resistance, and which impacts different organs that all lead to hyperglycemia. So different organs associated, just 3 of them, but we know there's also the heart, there's the brain, there's the gut, and many other organs involved in diabetes. So the IDF Atlas reported, the last one, the 10th edition, 3 years ago, they reported the prevalence of type 2 diabetes in youth ranked by region and ethnicity, and they revealed that the highest prevalence of type 2 diabetes, so a number of people with the conditions and youth and adolescents were highest in Brazil, followed by Canada, Mexico, and different populations in the US. But if I've looked, it's about, for 10,000, there are already about almost 2,000 type 2 diabetes in youth in the Brazilian population. The other thing was like per 10,000 people per year, the incidence in new cases diagnosed. You see Canada goes with almost 1,000 new cases per 100,000 children, adolescents, or youth per year, followed by the US, then Thailand, Hong Kong, and some other countries. So these are probably one of the very first indicators of incidence and prevalence of type 2 diabetes in youth, published in a large scale. Then Wu et al. In her article on diabetes research clinical practice in 2020, she evaluated all the publications on diabetes prevalence between 2001 and 2021, and then she extrapolated the data using regression models according to country characteristics to predict the current incidence rates of type 2 diabetes in children as adolescents, like under 20 years old. And if you have a look at this picture, it's probably not that surprised that the northern part of America, of the US, or the northern part of the American continent, has probably one of the highest incidence of type 2 diabetes, but also South America, like Chile, Argentina, have a very high incidence of type 2 diabetes predicted in youth. Large part of Africa, they're doing much better, but again, like the Gulf countries, they have a high incidence of diabetes. And if you'd overlap like the obesity profile and probably the physical activity profile, we would understand the potential reasons for that. She went further to present the cases also according to the different IDF regions and the World Bank income classifications, and revealed that according to the income classification, that upper middle income country had the highest incident case burden of type 2 diabetes in the youth, whereas in the IDF region, Western Pacific had the highest number of incident cases per 1,000 according to IDF region. The other region are pretty stable, but we had at least 5 cases per 1,000 in each of these regions. So these were one of the latest data we had. In a study published by Diabetes Care, they compared the prediction of type 1 and type 2 diabetes burden in the US population below the age of 20 through 2060. The objective was, the input data was like, they used the prevalence of 2017, and they used incidence data had available between 2002 and 2017 by diabetes type, age, sex, race, ethnicity. So these were the variables they used. And they projected 2 different scenarios. One was assuming a constant incidence, and I'm going to show you why this is not the realistic scenario. So with the constant incidence, they assumed that the incidence remains constant between 2017 and 2060. But there also a different scenario that if the incidence continues to increase as observed between 2002 and 2017, what will be the projections for the year 2060? And you could see that for the constant incidence projection for the year 2060, there will be a 3% increase in type 1 diabetes in youth, but a 70% increase in type 2 diabetes cases in youth. And if you consider like the increasing incidence scenario, which I think is more realistic, they're projected a 65% increase in type 1 diabetes, but almost a 700% increase in type 2 diabetes cases in youth. These are alarming figures. Lawrence in JAMA in 2021, he compared like prevalence and incidence data of type 2 diabetes per 1,000 youth in 2001, 2009, and 2017. And he showed that there's a constant increase, like in type 2 diabetes, all cases from 21, the prevalence per 1,000 youth was 0.304 in 2001. It went up to 0.46 in 29, and then in 2017, 6 years later, it was 0.67, almost doubled within 16 years. And the biggest increase is probably in the 15 till 19-year-old youth or population group, and also other like race ethnicity group. They all showed like a remarkable increase or doubling the prevalence of type 2 diabetes between 2001 and 2017. And then he had a look at the annual difference of percent change in prevalence of type 2 diabetes, even that the linear change was not significant. It doesn't necessarily have to be linear change, it can be an exponential change. And we can see like the annual percent change in estimated prevalence of type 2 diabetes between 2001 till 2009 was almost about 3.7%, whereas it grew about by more than 1% for 2009, 2017. That's why I think we can't assume like a steady state, a constant thing. Unfortunately, the annual percent change is increasing. It's not a linear increase. I would prefer rather to talk about an exponential increase. But again, these figures are alarming. A very recent publication of the SWEET study, they had about 1,000 records of 130 clinics all around the world to analyze. And they showed the percentage of new patients with type 2 diabetes, so incidence among all diabetes cases by region and period of diagnosis. And they showed that in all regions, basically, type 2 diabetes is increasing at an alarming rate. I'm not sure why the Asian region between 2018-19, it decreased from 18-19 to 2021, but all the regions really constant increase. They also had a look at the share of the different types of diabetes according to the years, where we see that there was probably over 90%, probably 94% of diabetes is type 1 diabetes in youth, like in 2012. But you can see how the orange part of the bar changed, that becomes wider and wider, which means the overall share of diabetes in youth is changing. And percentage of type 2 diabetes cases in youth is rapidly increasing in our youth population, unfortunately. Jesuita and co-workers, they also showed like a nice histogram overlapping like the age of onset of type 1 and type 2 diabetes. It's probably not a surprise like the type 1 diabetes onset, but if you have a look at the red histogram, it's really surprising like how early we already get type 2 diabetes, and that youth like after the age of 10, 12 can already be diagnosed with type 2 diabetes. This is something when I went to med school, usually type 2 diabetes was the disease of the older people or middle-aged adults and later, but this has drastically changed. And we really need to have some actions in order to curb that burden, to change this histogram, because youth, they shouldn't have type 2 diabetes as it occurs. There's another investigator, Pern, they reviewed in the search study the incidence of type 2 diabetes in US youth according to different race ethnicity categories. And they showed an increase specifically in non-Hispanic Black population. Hispanic was increasing as well. Non-Hispanic white was pretty steady between 2002 and 2016, but all the race and ethnicity categories, they showed increasing temporal trends of type 2 diabetes in youth use. Now, they also put together all the information that exists at the time. So they combined like a Wu's publication on the data she extrapolated. They added the IDF Atlas information and the search data to the same file, and ended up with this graph that really highlights very well like where we are standing and which are the countries mostly affected with cases of type 2 diabetes in youth. In the bottom, we see like the countries, the bigger populations, China, India, US, Brazil, Nigeria, Indonesia. But even in other countries, we have at least between 1 and 10 cases per 1,000 population of type 2 diabetes, new cases per year, which is really alarming because these children are going to live much longer time with the disease than usually adults do. There's also some information on the changes according to different race and ethnicity group in the US population as shown in this slide. So have a look at the orange dot is 2017. The two blue dots are very close together, but something happened between 2009 and 2017 that led to a drastic increase of the speed of the currents of the disease, that more and more type 2 diabetes patients diagnosed in that youth population. So again, alarming figures for our youth and our countries. There's a conceptual framework how different risk factors lead to the youth onset of type 2 diabetes. And I think we all know what the risk factors are, but we have to go a little bit deeper. We have to go into the social determinants of health, the health equities, the social environment, physical environment, because these are probably one of the roots of our society that probably leads to the early onset of type 2 diabetes. Has to be probably screen time, environment, institution policy, practices, risk perceptions. It has to be the physical environment, like the built environment, walkable cities, structures, neighborhood, community, environmental toxicants, as Dr. Schwartz pointed out in his presentations. Then we have the family and individual factors that probably results partly of the structural and contextual factors that are family related, individual related. We have non-modifiable risk factors, but we have also like family factors that are certain social determinants of health, education, income, access to health, certain shared family behaviors and home environment. And all this probably leads to the deterioration of glycemic control and to type 2 diabetes. So if you'd like to make any changes, we really have to dive a little bit deeper than just the risk factors or lifestyle habits, but we have to address the roots of these problems to make the changes to give the possibility to each youth to have a healthy lifestyle and a life free of type 2 diabetes. Now, the complications of youth onset type 2 diabetes are a little bit different because they usually have a poor glycemic trajectory, so higher metformin monotherapy failure rates. And also they have shown to have studies that a faster, a more rapid beta cell function decline. Also, cardiometabolic risk factors are more likely in youth type 2 diabetes patients compared with type 1 diabetes patients. And studies have shown that the microvascular complications 2 to 3 times higher in youth with type 2 diabetes than those with type 1 diabetes of similar age. So it looks like going through different clinical patterns. Also, preclinical cardiovasculars in youth with type 2 diabetes are increasing, and this is definitely an age group that shouldn't have cardiovascular disease or manifestation of the disease. Also, mortality in excess of type 1 diabetes counterparts in youth from the same population without diabetes have been observed, and advanced complications are more likely to occur. So these are some of the reasons why we really have to put emphasis in youth and adolescents with type 2 diabetes. To conclude my presentation, we are observing that the incidence and prevalence of type 2 diabetes worldwide has shown a heterogeneous increase in different territory. It is really important that we investigate more and have large-scale observational studies to understand better maybe old and new risk factors and go to the roots with the social determinants of health. We need probably new approaches and also epidemiological designs that we can approach better the epidemiological analysis of type 2 diabetes, similar than Dr. Diaz pointed out in regard to type 1 diabetes. So maybe similar concepts can be applied. And then finally, probably, as there's not much surveillance of youth onset type 2 diabetes in the world, there's not much monitoring. We have to set up our surveillance systems to include youth onset type 2 diabetes as well, in order to act fast and to see whether the actions we're going to take or the guidelines have it result in a change of the type 2 diabetes in youth. So I think a strong call must be made for the collection of trend data to assess the global burden of the disease in the youth and addressing fast, starting to act rapidly on the modifiable risk factors and living conditions of our youth to delay the progress of type 2 diabetes. And it's sad that I have to say that already in the youth, because usually this was something we said like for older adults or middle-aged adults, but it's the same concept and we really have to act fast. And with this, I conclude my talk, and I really like to thank everyone for the opportunity to provide this information to this very nice audience. Thank you.
Thank you, Noel. Thank you, Paula, for the wonderful talk and presentation. And I can see there are no more questions in the chat box. And I will ask Paula, do we have time for a couple of questions, or do we need to close the webinar?
No, to me, I'm fine. I have time. Thank you.
Okay. So let me ask Paula to you regarding the prevention of type 1 diabetes. Now, that is one of the very important topic, and you can say it is a breakthrough in the management of people with type 1 diabetes. Now we can delay the onset of type 1 diabetes. So how do you see the newer therapy like teplizumab now changing the management of type 1 diabetes, and what is your opinion on that?
I think that now we have hope. Really, we need to think in what is this gap between, for example, people that has the opportunity to change as user of these new molecules to really delay this really painful onset of type 1 diabetes, also reduce the complication. I think that is a very important topic. This is a very important momentum for people with type 1 diabetes. For example, also it's very important try to think in the new insulins, in the new ways of treatment, in the new maybe potential replace of beta cells. So this is very important to try to combine every strategy to really has the opportunity to reduce the amount of suffering and days with disease in the people. That the problem is really the diagnosis. Where is the people that really need to have this access to diagnosis? Is the whole population? What is the strategy? Or is really the certain people that, for example, has this family history in terms of childhood, brothers, sisters, cousins, grandpas, and everyone that really has the line of type 1 or type 2 diabetes, because I think that also this is one spectrum that we need to address more. This is one point, but another point to me that very critically before to move forward to treatment is people that died without diagnosis. This is still happening in countries like Colombia, maybe is still happening in countries like India, but our childs are dying without diagnosis. So this is not possible. So it's important to try to figure out how can we move together to avoid any preventable death in people with type 1 diabetes because of one cetoacidosis or complication without diagnosis. That is also another side of the story. There are some. Yeah, there are one question, but I can read. Okay.
Yeah.
The global burden, if there's any data from the global burden of disease, this may help in indicating the risk for type 2 in children and adolescents worldwide. I need to check. There hasn't been published anything on type 2 diabetes in children, so I need to revise with the global burden of disease group to see if there's any information. That's a very good point.
Thank you, Janvier, for highlighting that point, and Noel will look into that. And Noel, I would just like to ask, we are observing that the number of people with type 2 diabetes is increasing. The age at which the diabetes is happening is now getting lower and lower, and people at the younger age, they are getting diabetes. And you already mentioned that we need to dig deeper than the just physical activity and the lifestyle and the diet. So, what is your take-home message for our participants and all of us that what should be done to prevent diabetes in youth?
the first thing is that we understand that it's a problem, and I think, and we need definitely more data, but all the data we have shows that it's an increasing problem, and the most important thing is that we have to start act fast and to the root. So which means it's really about creating conditions for a healthy lifestyle, which means all the social determinants of health, access to education, to quality care, and that we start to work with a changing environment. We have a lot of children have a lot of screen time, they're moving less, their unhealthy eating habits. So we really have to create the conditions that our children can have a healthy life, free of the type 2 diabetes.
So Noel, there is another question also, and this is to anyone on the panel. And thank you, Angela, for asking that question. And she's asking that why do you think the collection of the data on diabetes can be difficult to obtain and supply further information in real time? And she's explained that her reason for asking is due to her past research in diabetes study as well. So any one of you.
Okay, I can start. Maybe in general, I mean, it's in order to collect real data without having good diagnostic criteria, a lot of population-based data collected by self-report. So we really need to have fasting glucose levels and 2-hour glucose levels and probably HbA1c as well. So it's logistically not that easy. It costs money collecting the data. The other thing is we probably don't screen that well children for type 2 diabetes, and it's probably maybe often this misdiagnosed of type 1 diabetes, as we were probably not that aware that type 2 diabetes can occur at younger age. So there's probably maybe some misclassification that we have to be aware of. And then it's probably just that maybe it didn't have any idea to look for. So this happened in type 2 diabetes in adults. When we started using all the screening questionnaires, we started to identify more and more patients with type 2 diabetes. In some countries, for every patient, known patient type 2 diabetes, we had an unknown screen detected patient with type 2 diabetes. So it's a logistic problem that can be solved, as we know what you have to look for. And this hopefully going to help getting more data on type 2 diabetes and type 1 diabetes in youth.
I agree with Dr. Berengo. I think that maybe I can add that now we live in a world that where sharing information is possible, that our system, technology, and maybe open source of analysis, it's possible to do things that maybe before not. So I think that we have to start to put all the people agree what is the minimum amount of data, piece of data that we will have to collect, that we will have to share, where, when, who win. This is very important also to try to understand that all together we can really understand and put in these big needs of what happened with type 1, but also type 2 diabetes, small pieces to really understand the big picture. So I think that we can do it. Organization maybe like IDF could also make orientation. Also, WHO or PAHO also can make orientation. Diamond, for example, has the intention also to set a minimum of recommendations and support people to increase the capacity building to really help communities, countries to understand how can and where we collect data.
So I think that answers the question of Angela, and it's time and to thanks everyone. So I would like to thank Dr. Peter Swartz, Dr. Sagar Dugani, Dr. Paula, Dr. Noel, and the team AMNET and all the organizations like ADA, IDF, APHA, and the University of Antigua and the Florida International University for coming together and organizing this very, very important webinar on the World Diabetes Day. It's a wake-up call, as highlighted by Dr. Sagar Dugani, and we need to reach out to politicians, we need to reach out to the doctors, we need to reach out to our patients. And this is the solution given by Dr. Peter. And Dr. Noel and Dr. Pola highlighted the problem, and they have also highlighted some of the solutions as well. So I hope everybody has gained some insights into the epidemiology of diabetes in different situations in different populations. So final comments from Noel and Pola, and then we can close.
No, I think it's also thank you so much for everything, for organizing it. As you mentioned, it's a wake-up call, and I think important that we work together, develop strategies in order to not only to monitor type 2 diabetes and type 1 diabetes in the youth, but also an action plan how to act it in all IDF regions.
Thank you. Thank you very much. Thank you for the audience. And I think that we have the responsibility to share, to spread the information across the whole world in our teams, in our countries, in our small or big opportunity to change this situation for all people with type 1 diabetes and type 2 diabetes, and also the cardiovascular disease that are also implied after all these diagnoses. So it is very important to, we have hope, we have things to do, so let's do it.
Yes, so we end on that note. And once again, thanks to all the participants and for asking so many questions and actively engaging during the discussion. Thank you so much.
Thank you. Have a great day.
Thank
Bye.
you.
Thank you.
Bye.
Bye.
Great
Bye.
meeting. Stay safe.
Hello,
Bye.
can I end the meeting? Hi, Paula, can I end the meeting?
Yes,
Anna
please
from
end the meeting. Thank you very much, Anna. Thank
okay,
you.
bye.
Bye-bye.
Thank you.
Bye.
Thank you.